Good morning, everybody. This is Harry. We are braving the COVID outbreak to do the first ever video brain cutting. So we're going to walk through step by step about how to cut a brain and what neuroanatomic landmarks to point out. So the first thing we did is we weighed this brain, and this brain weighed 960 grams. Second, after examining the cerebral hemispheres here, you can see there's narrowing of the gyri, widening of the sulci. So this is like frontal atrophy, temporal atrophy, and a degree of parietal atrophy as well. So this goes along with Alzheimer's patient, which what this patient is. I guess continuing to look at the cerebral convexities. When looking at the major gyri or landmarks to look at, the frontal cortex has a inferior, middle, and superior frontal gyrus. Additionally, the temporal lobe has a superior, middle, and inferior temporal gyrus. Okay. If you follow the frontal gyri back, you can see that they end right about here at this cortex that runs up and down. That is the primary motor cortex. Remember, you need to move before you can touch. And behind that is the primary sensory cortex. Okay? Between the two, you have the central sulcus that divides the primary motor and sensory cortex. Okay? Looking at the leptomeninges here, you can see that there are these granulations right here. Those are arachnoid granulations. Those resorb CSF. And then back to the leptomeninges. Remember, there are three layers to the meninges. You have the dura, also known as the pachymeninges, pachyderm, tough skin, pachymeninges, tough meninges. Then you have the arachnoid and pia, which together constitute the leptomeninges. Okay. Morning. Okay. Flipping the brain over, you get a look at the temporal poles right here. You have the unci, the mesial part of the temporal lobe. Okay. So having flipped the brain over, these are the unci right here, the medial part of the temporal lobe. And these are the olfactory nerves and the olfactory bulbs that lay in the olfactory groove. And then medial to them, you have this straight gyrus here called the gyrus rectus. And the reason why I point that out, it's probably not as helpful in adults, but in kids, you may deal with disorders in which the front of the brain doesn't come together quite right. Things like holoprosencephaly, things like that. But if you have the olfactory groove and gyrus rectus and olfactory nerve there, then you can be comfortable reasonably that the entire front of the brain has come together appropriately in a developmental sense. You have the optic nerve going to the optic chiasm, and then the optic tract behind it. And right here is where the pituitary would sit. And this is when you have a pituitary mass. It compresses the medial fibers in the optic chiasm, which is the lateral visual fields on either side. And that's how you get the bilateral homonymous hemianopsia, or tunnel vision with pituitary mass. And then, I already mentioned the optic tract. You have these little bumps right here, which remind me of milking a cat and that movie Meet the Parents. Those are the mammillary bodies. Okay, we have pons, medulla, cerebellar hemispheres. Okay. Now, looking at the, let's do the circle of Willis now. So we'll start from the base and work our way up and just discuss some of the major. So you have, I believe, it's either one vertebral artery and the other has been torn off, or this is all basilar artery all the way down probably. So we have basilar artery, comes up, branches into the posterior cerebral arteries, going around. This is a good one right here. So that's a posterior circulation. And the anterior circulation comes off of the internal carotid with the posterior communicating artery connecting up and up. Internal carotid right here going out into the middle cerebral artery that runs into the Sylvian fissure right here. What this thing is on either side. And then if you follow it anteriorly, you have the anterior cerebral arteries running in the interhemispheric fissure, right, let me grab it without macerating things, and the anterior communicating artery is this little thing right here, and it communicates between the two. So those are the major branches of the circle of Willis. I believe that's everything to describe before we go and amputate the brainstem. So when you amputate the brainstem, what you want to do, you want to look for the mammillary bodies, and you want to slide your knife flat over the mammillary bodies, like that. And you're amputating the brain stem and midbrain through the cerebral peduncles. And what you wind up with you should get a view of your substantia nigra, red nucleus, cerebral peduncles, also known as the crus cerebri and basis pedunculi, and cerebral aqueduct. And then you have these bumps right here. There's 4 of them, so those are known as the corpora quadrigemina, or 4 bodies, or the superior and inferior colliculi. Okay. So let's set the brainstem aside and section our brain. So when sectioning the brain, you want to hold the brain as plumb as possible. Plumb means level in all axes. And you want to cut the brain down through the mammillary bodies, like so. Then, you want to take the brain, and if you're right-handed like myself, you put it in the right-hand corner closest to you, and you want to cut the brain from the inferior to the superior aspect. The reason being that the leptomeninges are generally a little more dense and fibrotic on the superior aspect, and if you have a very soft brain, you're going to drag those leptomeninges through the brain and shred it when you're cutting, or at least you have a higher risk of that. Then you want to take it, and with a couple slices, cut your brain. Now when we arrange things in neuropathology, we arrange it so that the left is on the left and the right is on the right, the opposite of your imaging when you look at it. So the way you remember what to do is when you're cutting the brain, remember front flips. So you flip the front, and don't flip the back half after you bisected it like I have. You want to lay it out from superior to inferior or middle, working from the middle, working from the middle, you want to go anteriorly. So I lay my first section out in kind of the middle of my cookie tray and proceed outwards from there. Typically, like the minimum number of days to fix a brain, if it's, if the patient doesn't have a prolonged postmortem interval or a bunch of cerebral edemas, like 10 days to 2 weeks. Use your judgment, however, if the patient is otolized or if there's, if the brain is very soft when you remove it, it'll need to fix longer. Similarly, when suspending the brain in formalin, I've noticed since I've started back that we have a tendency to use the bonnets. The bonnets will kind of smash the brain and distort it. I mean, they're okay if that's all you have, but a better way is to take a string, put it under the basilar artery, and suspend the brain in formalin hanging from the string. You kind of put both ends of the string over the edge of the bucket and use the lid to hold it. That'll have the brain actually float there, and you won't have this kind of distorted brain that looks like it was drawn by Salvador Dali. So now we're on to the posterior half of the cerebral hemispheres, and we're going to do the same thing, except we do not flip this half. When you're cutting the brain, It's better to use long drawing motions. That way you don't saw it. If you saw it, you're going to get, a bunch of little ridges and stuff. So, I mean, they say ideally, and I've not been doing it myself, is you should do one long drawing motion. I typically wind up doing like a pull it towards me and push it away, and that's enough to get through the brain. But notice how I keep bringing it back to the corner. And it helps me have more control over my knife. I'm not reaching out across here. There's a tendency for residents, I noticed, to, this is everywhere, to, start in the corner and then the brain kind of creeps away and they keep chasing it rather than bringing it back to a place where they can work on it efficiently. So, keep doing this. I don't know if you want to pause it for the rest of that because I'm out of things to babble about. Hemispheres, and we're going to deal with our midbrain and brainstem. So the first thing you want to do is you want to put a light score all the way down your brainstem from the midbrain on down. What this does is, I put it on the left side every time, and if there's a lateralizing lesion, you will be able to tell on the slide by looking at the score which side you're looking at, because otherwise it's impossible. I guess the one neuroanatomic thing to show you guys, because I'm going to cut it, or at least go over with you, are these white matter tracts that run out of the cerebellum to the pons and the midbrain. So you have 3 cerebellar peduncles, and like many things in neuropathology, they've got 2 names. So the easy names are superior, middle, and inferior. But then the other names are the brachium conjunctivum, it crosses conjunctivum for the superior cerebellar peduncle, brachium pontis, it runs to the pons, and the rest, or the restiform body, that runs inferiorly. So those are the other names of the superior, middle, and inferior cerebellar peduncles. So now we are going to cut through the peduncles. Taking care not to cut our medulla. And we will remove the brainstem. Now we're just going to section this serially. Okay, first part I'm cutting through is the midbrain. And we'll just lay it out here. So I'm sectioning down through the quadrigeminal plate. Okay, this area, that area in the midbrain as well, the quadrigeminal plate has another name in general for that area. It's the tectal plate, or the tectum. Okay. Now we're getting into the pons. And when you're into the pons here, we have this space up on this part of the pons called the that's a fourth ventricle, and the part of the pons that corresponds to the fourth ventricle, or is near it in relation to it, is the pontine tegmentum. Sectioning down more inferiorly, we're getting into medulla, through the pontomedullary junction, down into the medulla now. This is fourth ventricle right here. When we discuss various tumors that occur in the posterior fossa, ependymomas will usually arise in relation to a ventricle, and a common place is the posterior fossa, so they're associated with the fourth ventricle there. Pediatric brain tumors tend to arise in the posterior fossa, although they can happen anywhere, whereas adult primary brain tumors are more commonly up in the cerebral hemispheres. Similarly, the most common brain tumor in the brain of an adult is a metastasis, versus the most common tumor in the brain of a child is a primary brain neoplasm. All right, now we're going to section the cerebellum sagittally. Start on the right and start cutting. You know, and you can cut the brain different ways. You know, I tend to, you know, this is how a lot of people do it, where they'll section the cerebral hemispheres in a coronal plane. But there's nothing saying that you can't section it axially or sagittally as well, if there's something you need to demonstrate better. Section it. Careful not to cut our fingers on film. That'll be pretty epic. Alright, so now let's lay this out. I typically, to keep left and right straight, I'll put the left side of the cerebellum on the left and the right side of the cerebellum on the right. It's nothing magical about it, just helps me to remember. Put the middle in the middle. And then when I'm looking at it, if I see a lesion, I'll be able to say which side it is on. All right. Let's start going over some anatomy. First thing, as we said before, this is the dura. The dura, or the pachymeninges, if you like to be fancy. The reason why I bring that up to residents is because there's a thing called pachymeningitis that you may read in radiology reports. So if you know what the pachymeninges are, you know what pachymeningitis is inflammation of. Okay? So the dura has this dense fibrous strip that hangs down in the interhemispheric fissure that separates the right and left cerebral hemispheres. That is the falx. And part of any examination, as you section through the falx and you look at this space right here, which is the superior sagittal sinus, to see if there's any kind of thrombosis. And we do not have anything from the patient's history to suspect such a disorder. A little bit of blood laying in there. All right, spinal cord. Okay, the spinal cord has the way you can tell front from back is the front has the anterior spinal artery running down the length. Okay, you have a cervical enlargement, then it gets skinny in the thorax, and then a lumbar enlargement. Down here, you have the cauda equina, or horse's tail, going down to the conus medullaris and the filum terminale. Okay, and there are certain types of tumors that like to happen down there, such as a myxopapillary ependymoma. It's like a little sausage hanging off of the filum terminale. And, you know, under normal circumstances, we'll make a couple cuts and see that the spinal cord has the gray matter on the inside and the white matter around the outside. It's kind of the opposite of the brain. So you look for any discoloration, any abnormalities there. If the patient has a history of weakness or hemiplegia or something, it's indicated to take some. And you know, under most autopsies, you know, may or may not be necessary to sample the spinal cord, although if you're a compulsive neuropathologist like myself, you know, and you're trying to do things right, you will. All right, let's go over the brain. Starting at the front, okay, you've got the big bunches of white matter that run the length of the brain. That is the centrum semiovalli. Okay, then we have this white matter structure that crosses from left to right. It's larger in women than it is in men, on average. That is the corpus callosum. Okay, so the corpus callosum has three parts. You have the body in the middle. In the front, you have the genu. So remember, when you genuflect or bend your knees, you make the shape of the genu of the corpus callosum. And in the back, you have the splenium of the corpus callosum. Okay, so genu, body, and splenium. There's actually, around the very front and the bottom, there's a rostrum as well, but that's not that important. All right, so then we get to these spaces right here, which are the lateral ventricles. Okay. And these are the temporal poles, or temporal horns of the lateral ventricles. Temporal horns. Okay. So these ventricles are large. So I would say there's enlargement of the ventricles. Okay, what do we call that when you have dilatation of the ventricles in secondary to loss of brain matter? That's called hydrocephalus ex vacuo. Okay. There's also hippocampal atrophy. In a normal hippocampus, you would not even be able to see this space. And in this individual, I can put my finger there and not smash the brain. So this goes along with the history of Alzheimer's disease. Okay. Now, progressing more posteriorly, we start to get a little hint of some gray matter structures that bulge into the lateral ventricles. These are the heads of the caudate nucleus. So we have a caudate right here. Caudate, 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 caudate. Notice how it gets smaller as it goes more posteriorly. So if I'm feeling sadistic someday and I take your brain and I jumble all up and tell you put it back in order because I want you to test your neuroanatomy, one of your caudate nucleus is your friend because it can help you decide what's more anterior versus posterior in some of these things, okay? So then, okay, we have this white matter stripe right here, which is Anya's favorite structure. That is the internal capsule. And the internal capsule separates the caudate nucleus from the putamen. Okay, it's caudate, putamen, putamen right there, putamen right there. Okay, both the caudate and the putamen histologically are gray matter with bundles or stripes of white matter running through them. So the name of those when taken together is a striatum. Okay, so where the caudate and the putamen come together, there's this ill-defined area right here. That's the nucleus accumbens. That's where you put the electrode in the rat's brain and they'll just sit there and stimulate the electrode and not eat and not sleep and not take care of their babies. Okay. So then if you look at the putamen, medial to the putamen, you have this area that does indeed look more pale. That is the globus pallidus. Okay. So, and that's because histologically, the globus pallidus, while it is also a mixture of white matter and gray matter, it's more diffusely blended together. Okay? So, in general terms, the caudate, putamen, and globus pallidus, when taken all together, is known as the basal ganglia. The globus pallidus and putamen, when looked at from the side, kind of look like a lens. That's called the lentiform nucleus. Okay? So I bring up these names. There's a method to my madness. You know, the other name for Wilson's disease is hepatolenticular degeneration. So if you know what the lentiform nucleus is, you'll know what part of the brain is involved by Wilson's disease. Similarly, there's neurodegenerative diseases and alpha-synucleinopathy, part of multisystem atrophy, called striatonigral degeneration. You know what the striatum is, that'll help you out in identifying what parts of the brain are involved. Okay. Laterally to the putamen, you have internal capsule, this is external capsule. Then you have this gray matter structure, which sounds like it was named after some German dude, that's the claustrum. Then you have this white matter structure right here, which is the extreme capsule. And it's a little bit late, but that's, you know, think about Harold and Kumar, go to White Castle if you watch movies that are, you know, like that. So then you have this cortex here, down inside the sylvian fissure. This is insulated down here. This is the insular cortex. This is a nice demonstration of the columns of the fornix. And the anterior commissure will cross the columns of the fornix and actually make a letter A. The anterior commissure is a good neuroanatomic landmark because it'll be a little bit deeper down in here. You'll have a gray matter structure that is the substance without a name, or the substantia nominata. And within the substantia nominata, there's the nucleus basalis of Meinert, which is the major site of acetylcholine production in the brain. Okay. We have this thin, delicate membrane that hangs down from the middle of the corpus callosum. That is the septum pellucidum. And we have this gyrus right up here above the corpus callosum. That is the cingulate gyrus. Proceeding more posteriorly, we have the mammillary bodies that have been sectioned in thalamus. More posteriorly still, we have this structure right here that kind of looks like part of Napoleon's hat. This is the lateral geniculate nucleus. The lateral geniculate nucleus, we have it on both sides here, is an important neuroanatomic landmark because that is the level where you want to take your section of the hippocampus. Okay, that's how we standardize what section of the hippocampus you take. This part of the hippocampus, the curlicue-shaped structure, is called Ammon's horn, named after the Egyptian sun god Ammon-Ra. He had a ram's horn with him, which was curlicue. Okay, and the different areas in that are actually broken down into CA 1, 2, 3, and 4, which will be a discussion when we look at this brain microscopically. And the CA actually stands for corneomonas, or Ammon's horn. That'll help you remember. Okay. Right below the Ammon's horn, you have the subiculum, and then the entorhinal cortex, right here. Okay. So declarative memory, after the sensory information is integrated, kind of starts in the entorhinal cortex, goes to the hippocampus, I believe, by something called the perforant pathway, goes through the hippocampus, it exits via this layer of white matter on the outside of the hippocampus called the alveus. I remember the chipmunks, so they're not the Simonius or the Theodorus, it's the alveus. That connects to the fornix, columns of the fornix, comes down to the mammillary bodies, then through the mammillothalamic tract, which I believe this white matter stripe right here is a little bit of one, although don't quote me on that, I guess on video we are. And then it goes to the, I think it's the medial dorsal nucleus of the thalamus. So that wiring that I described for you is called Pepez's circuit. It's a memory circuit, okay? And, there's clinical import to that. Patients with bilateral hippocampal sclerosis have an anterior grade amnesia. Alcoholics that destroy the mammillary bodies have an anterior grade amnesia, but classically, alcoholics will confabulate, whereas hippocampal sclerosis patients may not. That's because it's the same circuit disrupted at slightly different points. If you go anterior a little bit, this is another part of the hippocampus. Notice it's not like a curlicue, it's more like a squiggly line. That is the small, crunchy, sweet part that comes out of head-shaped dispensers. That is the pes of the hippocampus, but if pes helps you remember it, would be my guess. Okay. And then anterior and a little bit superior, we have this structure here that looks kind of like an almond. That is the amygdala. That is part of the limbic system, and it is also one of the first places it gets alpha-synuclein deposition in dementia with Lewy bodies. The very posterior part of the hippocampus, or I'm sorry, the thalamus, is this big nucleus right here. It's called the pulvinar nucleus. We have these structures here in the ventricles. This is choroid plexus. This is where CSF is produced. This is actually produced by like an invagination, I believe, of mesoderm into the neuroectoderm. So you can rarely get like sarcomas in here, and you can rarely get like an interventricular meningioma arising from that area. Going more posteriorly, we get to this area right here. So if you look at this bit of cortex, you can see that there's a thin white stripe running in the middle of it.
Line of Genari.
That is the line of Genari. Very good, Elena. Yeah. The line of Genari signifies that this is the primary visual cortex. Okay, it aligns the calcarine fissure, and this is sometimes called calcarine cortex. Okay, not only is important because it's the primary visual cortex, but it's also the last place where people tend to get neurofibrillary tangles in Alzheimer's disease. So we stage the amount of neurofibrillary tangles by Brock staging is what it's called, and Brock 1 through 6, and Brock 6 is neurofibrillary tangles in the primary visual cortex. Let's go over and look at the brainstem. Okay, so we got the midbrain here with these big bundles of white matter. These are cerebral peduncles, crus cerebri, or basis pedunculi. And we have the substantia nigra. And the substantia nigra, like a lot of things in the brain, functionally has different areas. There's the pars compacta and the pars reticulata and some other ones. Okay. Then you have a space right here. That's a cerebral aqueduct. You have the colliculi, the tectal plate. Getting down into the pons. This is a better one of the pons. You have the basis pontus, the fat belly of the pons. Pontine tegmentum up near the fourth ventricle. There should be little blue dots here, or little dark dots. You can barely make them out. That's the locus coeruleus. It's a major site of norepinephrine production. And you have, what you guys got to remember what's made in the substantia nigra. That's dopamine. And then in the midline of the pons, you have the raphe nuclei, which makes serotonin. Then going more inferiorly, you get into the medulla here. You got the medullary tegmentum around the fourth ventricle, and the main structures in the medulla that you can pick out grossly are this little nucleus that's shaped like a squiggly line. It has inferior olivary nucleus, and it's right adjacent to this white matter structure, which is the pyramid. And an analogy I like to make is if you have a triangular martini glass, have your olive up and to the side from it. Okay. So then the inferior olivary nucleus is actually wired up to this cerebellar nucleus, which is the dentate nucleus. Okay. The dentate nucleus is one of 4 cerebellar nuclei. The way you remember them is don't eat greasy food, dentate, emboliform, globose vestigial, or if you want to be pejorative, fat guys eat donuts. Okay. The midline of the cerebellum is the vermis, and I believe that's everything I can think of right now.